Patient Safety and Quality Clinical Excellence Queensland has developed a podcast series for Queensland Health staff and Hospital and Health Board members to hear from guest speakers on topics relevant to safety and quality in short bite-sized segments. All episodes are recorded on the lands of the Yagara and Turrbal people. We respectfully acknowledge them as the traditional custodians of Meanjin and pay respects to the elders past, present and emerging.
Hello and welcome to another episode in our Patient Safety and Quality podcast series. In this episode, we'll be covering a foundational overview of clinical incident management and how that applies in the context of Queensland Health, including key roles and functions of the Hospital and Health Board. My name's Denis Morton. I'm the Director of the Patient Safety Net program at Patient Safety and Quality Clinical Excellence Queensland. With me today is Dr. Lynnette Knowles, who is a specialist medical administrator and has been involved in and led clinical governance in hospitals and services across Queensland. Hello, Lynnette. Welcome and thank you for joining us today.
Hi, Denis. It's a pleasure to be here.
So, Lynnette, we're covering clinical incident management today. What exactly is clinical incident management and why is it important?
This is obviously a great question, Denis. I think first, when thinking through the question, we have to first consider what exactly a clinical incident is. So a clinical incident is any event or circumstance that's resulted or could have resulted in an unintended or unnecessary harm to a patient or a consumer. So when we think about clinical incident management, we're thinking about a system and process which is put in place to ensure the safety of our patients or consumers, their families, our teams, and the organisation. And when we think about why we have or why we need to identify a clinical incident and why we need a clinical incident management system, really we've got to go back to why. And really the objective of the SIM is to ensure that our systems are as safe as possible. We do this by responding to the event as it's happened and by learning from what's gone wrong or nearly gone wrong in the past so that we can put measures in place to reduce the likelihood of them happening again.
And it is such an important process when we are looking at preventing these potential harms from occurring again. And you made it sound so straightforward, Lynnette, but I know it is complicated. How is it done in Queensland Health?
Oh, you're really right. Healthcare is supremely complex. And so it's really important that any SIM approach is flexible to ensure that people are supported to respond in a way that best suits the situation, their people's needs, and their organisation's expertise, and first and foremost, safety. So there are many different ways to undertake clinical incident management, but the important point I think to make here is that there are definitely some basic steps which could inform any framework adopted for SIM by any HHS. The great news is Queensland Health has developed the best practice guide for clinical incident management, which is a really helpful guide for senior leaders, clinicians and clinical governance teams in developing their own system.
Excellent. Can you take us through those steps that are outlined in the best practice guide?
Yes, there are 6 steps that we need to be thinking through for clinical incident management. The first step is well before incidents happen, so before the incident, and thinking through how we may respond to any future incident as it occurred. The second is an immediate response. The third step is preparing for analysis. The fourth is the analysis process. The fifth is follow through. And the final step in the framework is closing the loop, which is incredibly important. And we'll get to that, I'm sure, a little later. So when we're thinking about step one, as I mentioned before, is a really important proactive step. And it encourages us to build a response system. When we have a culture within our teams, our units and our organisations, which are based on a culture of safety and a restorative just culture, we have the best opportunity to really respond quickly and effectively to support people. So step one requires a whole of organisation approach and incorporates leadership responsibilities at every organisational level. This includes board directors, executives and senior leaders. A SIM system for a HHS should be grounded in good governance approach, which includes having clear roles and responsibilities, having policies and procedures and reporting tools, just to name a couple of aspects there, Denis. When people are aware of and using clear systems, the really great thing is they're empowered to respond compassionately and transparently, which is what we want.
That's great. I really like that, Lynnette. I like that everyone in the organisation is playing a role to try to prevent the incident from occurring in the first place. So laying those foundations to prevent the incident from occurring. But healthcare is complex, and despite our best intentions, sometimes things don't go as we plan. So can you talk us through what happens when an incident does occur?
Yeah, when an incident does occur, it can be very traumatic for the people who are involved. So it's patients, consumers, families, carers, and also our clinicians. So the immediate response after recognising an incident has occurred is to care for and support the patient, the family, as well as ensuring the safety of other patients who may be at risk. We must also really ensure that we're caring for the wellbeing of our staff involved. So steps also need to be taken by the treating team to make sure the situation is safe, such as providing immediate care and ensuring the environment and the equipment is also safe to continue use. Sometimes this requires a quarantining of equipment and consumables, and it's also a really good time to let senior leaders know what has happened.
That's a really good point. And I think this is when the leadership in an organisation really can shine. When senior clinicians and leaders are able to lean in and support clinicians providing care for the patients, and also to speak with and support the patients or their family members. They're also able to take those steps to ensure the safety of the environment and the service. Continuing on this point around supporting the consumers and their families, how do you engage with consumers throughout the clinical incident management process? Are there any specific requirements?
Yeah, so going back to your last point, Denis, having leaders involved is incredibly powerful response. It supports everyone who's involved. And leaders continue to support patients and their families as they're moving through their journey. So when we think about consumer engagement, looking at the framework, we have two core conversation times. The first we refer to as clinician disclosure, and the second is open disclosure. So clinician disclosure is a conversation which occurs as soon as an incident's happened, so that we've had harm to a patient or consumer. So ideally, the senior clinician who's involved in the care speaks directly to the patient and or the family and advises them of what's happened. They also have an opportunity to provide an apology that things hadn't occurred as we had planned, and to advise what the next steps are, including what's the ongoing patient care that we provided, who's going to be in contact with the family, and what are we going to do next. It is really important to note that this is a time where not much will be known about what's happened through the incident and how it occurred. The second conversation that I mentioned was open disclosure, and it occurs often across a number of meetings or a number of different conversations with the family or the patients and consumer. So this conversation is often led by a trained senior leader of the organisation and provides families with an opportunity to share their experience and knowledge of the incident, to have their questions answered, and also for the open disclosure team to provide support and guide the patient, consumer and their families through the clinical incident management process and ensure their ongoing care. So the overarching aim of open disclosure is to ensure that patients and their families have reliable, caring and effective ways to receive honest and factual information about the clinical incident associated with their healthcare, while our clinician disclosures occur for all types of harm. Open disclosure is offered for patients and consumers when permanent harm, death, or a significant event has occurred. So the timing of conversations is important, and different patients and families will also have different needs during these difficult times.
It's such a good point with the disclosure, and from speaking with plenty of consumers over the years, I know that that's something that they find really valuable, being told what happened, but also being involved in the incident review process and being kept up to date with what the hospital and health service is doing. So I think that's a really good point, and probably a good opportunity to mention that there are some great resources on the Patient Safety and Quality website to support staff with the disclosure processes, because they're hard conversations to have.
They are really hard conversations. And I think just to add to what you've said there, Denis, I think having a compassionate and trusting conversation is really critical to taking trust into the future. Our patients, consumers and families need an ongoing relationship with us, and having these conversations is really critically important.
Yeah, so right. So Lynnette, getting back to step 2, we're focusing on the immediate risks and then what happens next.
So next is that the incident needs to be reported, and we usually use RiskMan through a healthcare system, and particularly in Queensland Health. So RiskMan is a database system that guides clinicians through a series of questions which are important in understanding what has happened and determining how we approach the next steps. So RiskMan also is an automated system, and the really great thing about RiskMan is that it alerts people across the organisation that an incident has happened, so that they can also take appropriate steps to ensure safety and trigger the clinical incident management system. So each role in the organisation will have a different responsibility in responding to the incident, but we'll work together to assure that the SIM response within the HHS is tied together and complete.
Very good. So the different types of incidents that occur will have different levels of reviews that follow. How are clinical incidents categorised within Queensland Health?
Okay, so we have 4 types of clinical incidents that we categorise. The first, and I mentioned just previously when offering an open disclosure, we refer to as SAC1s, so Severity Assessment Code 1s. Now, a SAC1 is a death or likely permanent harm which is not reasonably expected as an outcome of healthcare. So SAC1 clinical incidents, as you can imagine, require a deep understanding of what's happened, and with that comes an understanding of the resources and the people and the responsibilities behind it. So we have a really defined process around SAC1s. The next category is SAC2, and we define that as temporary harm which is not reasonably expected as an outcome of healthcare. The next is SAC3, which is minimal harm, which is not reasonably expected as an outcome of healthcare. And the final category is SAC4, and that is no harm or near miss. So as I mentioned previously, by defining the incident, we can best delegate responsibilities and actions to the right roles and ensure safety and quality and a clinical incident management response for our HHS. So later on, the categorisation helps us to understand clinical incidents and trends and assist monitoring and pre-incident actions to happen as well.
Okay, but with those categories, someone might be given a SAC2 rating initially because we think that there's temporary harm, but we haven't got all the information just yet because we haven't conducted the review just yet. So what if we do the review process and we find out that there's permanent harm? Can we go back and change it to being a SAC1?
Yes, you absolutely can. And just to that point, Denis, I think what's really important to also point out is that categorising is not a punitive event. So when we're looking at reporting, we're looking through the lens of improving our systems and making things safer. So when we look at our categorisation, it's really important that we get them right. And that means making sure that if it is a severe event, that we're categorising it appropriately without the fear of repercussion. Equally, if we categorise too high, we need to have the ability to correct the system and reflect appropriately. So the nice thing about RiskMan is you do have the ability to both upgrade and also downgrade as more information comes to light, because you're spot on. You never have the full facts at the very beginning, do you?
No, and that's really good that you make sure that the classification is accurate, but it's probably worthwhile pointing out for the boards when they're receiving their reports about clinical incident data, it might be true and correct at that particular point in time, but it may change. So they may see on today's date that there's been 3 SAC1s within the last 6 months. And then when they receive an updated report in a couple of weeks' time, it might say there's only been 2 SAC1s because one's been downgraded, but it's true and correct at that particular point in time. And that might be the reason why we see changes.
Yes, absolutely.
So what are some of the reporting requirements for SAC1 clinical incidents under the Patient Safety Health Service Directive and the Clinical Incident Management Guideline?
Okay, so for those who aren't aware, the Patient Safety Health Service Directive are a number of points that health services need to make sure that they tick off in order to have a baseline level approach to patient safety and clinical incident management. So number one, and most important, we've just touched on it, is that reporting of all SAC1 clinical incidents in RiskMan within 1 business day of becoming aware of the SAC1 event. So that's really critical. And again, that's all about letting the system know that something's happened and mounting a response to the safety event. The next is that there is an expectation all HHSs have an established, documented local process for identifying, managing and reporting any clinical incident that has resulted in actual or potential patient harm. And that really is the clinical incident management system that we're currently talking about today, and those 6 steps and executing on those. But ensuring people know how that is occurring in HHSs is really critical. The third point is that HHSs should also have a local process for directly escalating significant clinical incidents to the Director General of Queensland Health. So again, that's knowing how we get information from a critical event all the way through our chain of communication up through to the state level, and having a really clear understanding of whose role and responsibility that is. The next is that we need to conduct an analysis of all SAC1 clinical incidents and submit a report report to the PSQ, Patient Safety and Quality, for Clinical Excellence Queensland. So that needs to be done within 90 calendar days of the clinical incident being reported as a SAC1. Again, this is really important in order to ensure that our patients and our families are getting information as soon as possible, but also making sure that we're proactively and timely responding to the event as it's happened. And finally, the final requirement that we need to make sure we complete is that when we do review our SAC1s, that the report which is provided contains a factual description of the event, the factors identified as having contributed to the event, and recommendations to recommendations to prevent or reduce the likelihood of a similar event happening again.
So we might cover off that in a bit more detail later on the podcast with what we're finding from the incident review and developing the recommendations. But we know now at this point, the incident's been reported and it's been given its SAC rating. What happens next in the incident management review process?
So the next step for us here is to prepare for analysis. So as you and I have both pointed out, we know so little at this point in time once the incident has happened. So it's really important that we gather our information and understand at the very preliminary level what exactly has happened. The way we do that often is through a chart review and through initial early conversations for us to get an understanding. And this is really important because it helps us to understand what category we're going to apply to the clinical incident. So for a SAC 2 to 4, for instance, clinical incidents usually occur, they'll be reviewed by the clinical leadership team. So that might be the nurse unit manager or the director of the department to give a cursory understanding of what level that incident might be. For incidents which are SAC1, it's most likely that the HHS's clinical governance unit will provide leadership to the process and really get us started through this analysis step. So I might talk a little bit more about SAC1s because I think that's one of the areas that people need most information about. For SAC1 incidents, there usually is some variation between HHSs in terms of how they respond to clinical incidents. However, usually a triage team is used by most HHSs. What I mean by a triage team is a group of experts from the organisation who come together, who have expertise in clinical governance, clinical service provision, HR and legal. And this team sits together to really work through whether or not the category has been applied appropriately, what analysis needs to be undertaken, whether or not open disclosure needs to happen, whether the regulators that are appropriate have been contacted, and the next steps that need to be taken as we move through review analysis. This team is really important in setting up the review and ensuring that we have the right expertise to move through to the next steps. The team also identify whether or not there, as I mentioned before, any other regulatory issues occur. And I will just pull out that notifications to the Queensland Police Service, the coroner, and also the Office of Health Ombudsman are really important to consider at this point.
Yeah, good points. And you mentioned that there might be some variety between the hospital and health services with who's involved or their approach to that, the commencing the review. And we know that Queensland Health doesn't stipulate to hospital and health services what type of analysis must be undertaken. But are there any requirements that a HHS must follow within Queensland Health?
Yeah, so Queensland has legislation under the Hospital and Health Boards Act 2011 and also the Hospital Health Board Regulation 2023 that outlines these requirements. So these requirements are also supported through the Patient Safety Health Service Directive, which we mentioned a little earlier, and that specifically speaks to the monitoring, reporting and response requirements for HHSs in terms of SIM. Linked to the directive is the Clinical Incident Management Guideline that provides further instruction and direction regarding best practice for SIM. So you can see this is a full framework from Act all the way through to Health Service Directive and to the guideline. So within that, all requirements for HHSs are covered off. So certain SIM analyses do have some requirements under the Hospital and Health Board Act. In particular, Part 6, which is a clinical review, and Part 9, which is health service investigations. These can only be commissioned by the Director General or the Health Service Chief Executive. We also have root cause analyses, or RCAs, and they can occur if an event is a reportable event. For example, the surgery performed on the wrong site, resulting in serious harm or death.
Okay. I know with the RCAs, the root cause analysis, there have been some recent changes to the Hospital and Health Board Act, meaning that key findings, recommendations, lessons learnt can now be shared in limited circumstances. And I think that's really great for making sure that incidents that occur in one particular area might be able to be prevented in other areas because we can finally share those lessons learned.
Yeah, you're spot on. I'm like, that's the whole point we're doing these reviews and putting so much time is trying to prevent harm happening in the future. And I'm like, what greater benefit do we have than sharing from others' experiences? So I think really important.
Really positive change. So when would you suggest the use of a root cause analysis?
A root cause analysis, as I've just spoken about, is legislated under the Act. So it's a legal instrument that's used to ensure legal privilege. And with that, ensures that the information held within the report or the report itself cannot be, is not admissible in a court of law. So with that comes certain requirements by the HHS in terms of protecting the information, ensuring that it's confidential and provided only to named individuals. So we really need to have a lot of due diligence around that in order to keep protections around RCAs. So if we were to suggest the use of RCAs, it would be when we really wanted to keep legal privilege for certain matters.
Yeah.
But I will probably note there's probably more of a trend over time to step back from RCAs so that we can more openly and transparently share information.
Yeah, I think that's great. And I would imagine the reason why it has been used historically is so people feel comfortable to be as open as possible through that incident management process because they know that it is privileged. So some of that information might not be shared externally. But as we move towards a safety culture where people do feel safer to speak up, then maybe it's not going to be utilised as much.
Yeah, and that's such a great point because we are at a point where people are very open now in speaking about incidents and being able to really understand what has happened. I think it gives people a great deal of insight into the environment, into patient safety and the culture that sits within their organisation. And I think it's a great indicator that fewer and fewer incident reviews are actually RCAs.
Okay. So my next question then is around when an incident occurs, when would you not follow a typical incident analysis process?
So this is an important question. And I think I might start off by saying that our clinical incident management system largely looks at the systems and care processes which are in place to improve safety. So this is really important that when we think of SIM, we don't forget that there are other concurrent processes and regulatory bodies who may also have a role when an incident occurs. So through SIM, we're looking closely at systems and safety systems, and there are others who may have other lenses that they need to apply to what's occurred. There are professional and HR matters which may be flagged and are related to individual performance issues. So this could include professional behaviour, which should be notified through to the Office of the Health Ombudsman or AHPRA, or indeed criminal or even blameworthy acts which may occur. So in these cases, the SIM process needs to partner with other review processes, and in some instances, the SIM process needs to stop for other entity investigations to occur.
Okay, so I heard you mention blameworthy, which is a really interesting term. Can you talk about that one in a little bit more detail?
Yeah, so blameworthy acts really cross the line from genuine mistakes to recklessness or intentional harm. The Hospital and Health Board Act defines a blameworthy act as one of the following. It's an intentionally unsafe act, it's a deliberate patient abuse, or it's conduct that constitutes a criminal offence. The other side of the coin is notifiable conduct, and that's defined under the Health Practitioner Regulation national law and requires mandatory reporting to, in Queensland, the Office of the Health Ombudsman if there is reasonable belief that the health practitioner has either 1. Practiced while intoxicated by alcohol or drugs, 2. Engaged in sexual misconduct in connection with the practice of their profession, 3. Placed the public at risk of substantial harm in the course of their practice due to an impairment, or 4. Placed the public at risk of harm due to a significant departure from accepted professional standards in practicing the profession. So notifiable conduct requires the organisation to report this behaviour directly to OHO. It's mandated. There are other types of notifications we have that I should also just pick up, and they are voluntary notifications. So these also can be made to the OHO. They don't necessarily reach the threshold of the notifiable mandated conduct. However, it is important to note that there is a grey scale here, and that voluntary notifications provide an opportunity for safety and quality reporting as well. And finally, there have been changes with OHO too that extend the opportunity to report unregistered health practitioners where public health and safety is also at risk. So there is quite a few notifying and reporting obligations there.
All right. So blameworthy the act might not necessarily be if the clinician makes a mistake, because we know mistakes happen.
Yes.
It's when there's that intent behind their actions, or if they're intoxicated, things like that, things that you wouldn't expect in the workplace.
Yes.
Okay. So we'll head back to the steps now. I think we're up to step 4 now. We've chosen the method of analysis. What happens next?
There are lots and lots of processes that can be used for analysis, but really when we look at all of these processes, what we're trying to ensure is that we have the basic principles and steps within analysis for us to understand what has occurred. We need to determine how and why it has happened, and also identify any contributing factors and opportunities for improvement so that we can then develop and manage the recommended actions with, as I mentioned earlier, the final objective, which is to improve the safety of our system.
Yeah, and that's what it's all about. So finding those recommendations to prevent a similar incident from occurring again in the future. So the recommendation development is so important, but it's really tricky to develop recommendations that have the high impact, that are easy to, or not easy to implement, but implementable. Can you take us through the recommendation process in a bit more detail?
So good recommendations need effective implementation, and that is going to lead on to safer care and better outcomes for our patients and consumers. So recommendations should be directly linked to the findings of the report analysis, and they should also have a really clear connection to improving safety outcomes as well. So a great way to think about recommendations is using the SMARTER method, and I'm sure many listeners out there have heard the SMARTER acronym, but for those who are new, I'll quickly run through it. A SMART recommendation or a SMARTER recommendation is specific to the action required, is measurable on processes and outcomes, is achievable by your service, is relevant to the issues and realistic to achieve. It's timely for implementation, so it needs closure dates. It's effective to reduce the risk of recurring, and it's reviewed to achieve intended outcome, and so will not negatively impact other areas as well. So SMARTER is really important to keep very front of mind for review teams when they're putting through a recommendation. Without all of these aspects, recommendations can fail. And of course, recommendations take resources, and that's certainly not something we want. So when we look at recommendations, there's a lot that needs to happen from review, and I would really pull out here board directors and executive leaders have really key roles in endorsing and monitoring clinical incident management performance, and they can do this by ensuring that governance and legislation requirements are met, and also considering the effectiveness of their potential recommendations, and assessing the necessary resources and the sustainability of strategies. They also have a role which is critical in disseminating the report findings and recommendations. And this is really important as lessons gained in one clinical area can absolutely be applied to other clinical areas. And of course, it's just central to excellent safety culture approach as well.
I'm really pleased you mentioned the effectiveness of the recommendations, because something that I've seen over time is a couple of the most frequently used recommendations that we want around developing a new work instruction or guideline. And we know there are thousands of guidelines out there. It's hard for staff to keep up with them. It'll be delivering an in-service to staff, but staff turnover. So they're not always going to be there. So the people that are really skilled with their recommendation writing will go for those with the higher effectiveness that might have forcing functions with them as well. So I think that's a a good point to mention that the effectiveness of the recommendation is worth looking into.
Well, yeah, and I think it's important for staff as well, and for patients. If we're going to be really truly set on improving the safety of our system, then setting up these recommendations to succeed is absolutely critical. And equally, when we think about smarter, reviewing and making sure that that recommendation is hitting our targets is really critical as well, because if it's not, we should be stopping and we should be rethinking through that and really apportioning resources best.
Yeah, I agree. So we've done the review. We've developed some excellent, smarter, highly effective recommendations. What's the final step in the framework?
So the final step is closing the loop. And that really essentially is sharing what was learned both internally and externally so that we get biggest bang for buck in the safety of our system. So sharing within the organisation includes closing our loop with the patients and families, and we often do that through open disclosure. It's also sharing with the clinicians and the clinical team as well, because they're going to be very interested in how they change their practice for the future and what they could learn from the clinical incident. The executive team and board also have, as I mentioned, a great opportunity in terms of leadership of patient safety culture and the learnings that they receive out of the clinical incident reviews. And finally, we have the opportunity to share through our quality assurance committees, or QACs, and through our clinical networks and strategic advisory groups as where needed. And patient safety quality plays an extraordinary role in helping us support externally the sharing of the lessons that we've learnt through the clinical incidents that have happened.
Yeah, I think that's a really nice point, Lynnette. So we don't have to work in isolation. We can really share the lessons across the whole state. I have really enjoyed this conversation. So we've been through the whole process of clinical incident management. Thanks very much, Lynnette. I'd be keen to have you back for another podcast where maybe we can talk about what the board should be looking for through clinical incidents. Things that little tips for them with the board safety and quality meetings. Would that be all right?
That'd be terrific. Look forward to it.
Excellent. Thanks very much, Lynnette.
Thanks, Denis.
Now that draws a close on this episode. Further information regarding clinical incident management, including the best practice guide, can be found online at both the Queensland Health public-facing website and QEPS. Thanks for listening.